Hello, this is Jose Enriquez with U.S. University, and I'm going to present a case study that we had this past Tuesday, December the 9th, at my preceptor's clinic here in McAllen, Texas. The patient's initials are R and V. He's a 66-year-old male who came in with complaints of his joints hurting. Now that the weather's getting a little cooler, he said that it was his joints were beginning to bother him. So he presented to the clinic with also a history of acute kidney injury progressing to end-stage renal disease. And he's currently doing peritoneal dialysis, and he has been doing that for 4 years. But he presented with worsening joint pain, particularly in cold weather. The pain involves his knees, his elbows, his hands, and he described them as, quote, achy and stiff. And now his pain does fluctuate, but worsens with activity and cold exposure. No redness or swelling were reported that day, but joint flares do occur intermittently, he claimed. He has a strong family history of gout. His father and his siblings all have gout, but he denies any fever, chills, new trauma, or any type of recent infections. He has been listed for a kidney transplant now for 2 years. So in his past medical history, he does have acute kidney injury leading to end-stage renal disease. He has a history of hyperlipidemia, hypertension, obesity. He is currently taking Ozempic, 1 milligram weekly, simvastatin, 40 milligrams daily, and metoprolol, 50 milligrams daily. Like I said, in his past surgical history, he only has a peritoneal shunt dialysis placement in his abdomen, midline, and upon inspection, the insertion site was clean and not infected. It was no drainage and did not look inflamed. He did not have any drug allergies, and his vaccinations were up to date. Like I said, in his family history, father and all 4 siblings have gout, but there is no known family kidney disease among the family. He is the only one whose kidneys, for some reason, decided to go into acute kidney injury. In his social history, he's a retired truck driver and a former baseball and football athlete in his college days, and also did extensive heavy weightlifting. He denies tobacco, alcohol, or illicit drug use, and he lives with his elderly parents because he is currently divorced. On his review of systems, we did his musculoskeletal system. We did see joint pain, stiffness, but there was no edema. On his peritoneal site, there were no recent catheter issues. He does his peritoneal dialysis during the night hours as he is resting. His cardiac, there was no chest pain, no palpitations. His overall constitution, he denied any fever, chills, and his neurovascular, no weakness or numbness to any part of his body. His vital signs were all within normal limits. And his physical assessment, general overall, he was very alert, well appearing, no acute distress. But he did have, when it came to musculoskeletal, mild tenderness of his knees, elbows, and metacarpal phalangeal joints. No erythema or warmth noted, no morning, but he did have mild morning stiffness, and we did not see any type of swelling at the fingers or feet or his toes. Cardiac wise, there were no murmurs, clear to auscultation lungs, bilaterally, intact strength and sensation for his neuro. And so his assessment is pathophysiology. He asked me what could have possibly caused his kidney injury, and there are several things. There were 2 things, in fact, and one was probably microglobinemia and kidney damage because of the extensive muscle damage that he was doing for years and years, or elevated uric acid levels because of his familial genetic traits. He could have chronic hyperuricemia that can induce intrarenal crystal deposition or leading to inflammation, endothelial dysfunction, and ischemia. Now, so my primary diagnosis was gout, and my secondary was osteoarthritis to multiple joints. Thirdly, we came up with renal osteodystrophy related to secondary end-stage renal disease. His fourth was uremic neuropathy, and lastly, statin-associated myalgia, because he has been on simvastatin. So again, our plan was to alleviate his symptomology, get some lab works done. We started him on allopurinol 100 milligrams daily to maintain his uric acids under 6. Start colchicine, 0.6 milligrams every other day for flare-ups. For acute flares, we did also ordered low-dose prednisone, but instructed him to avoid NSAIDs due to his renal failure. Encouraged hydration within, of course, dialysis guidelines. And dietary counseling. We said, please limit your purine-rich foods like red meats, alcohol, and shellfish. Okay, he was not a drinker, so that part was not an issue. When it came to his end-stage and kidney preservation plan, while awaiting his transplant, we told him to continue with his dialysis, monitor for microglobulinemia accumulation, continue his metabolic control with Ozempic, continue simvastatin and metoprolol as prescribed. When laboratory-wise, we ordered uric acid levels, ESR, CRP for inflammation, CMP, PTH, vitamin D for renal osteodystrophy assessment, and we did order a beta-2 microglobulin levels to see where he was at. Lifestyle, we said please do gentle aerobic exercise, stretching to prevent joint stiffness, but also apply warm compresses during cold winter. Avoid heavy lifting due to joint strain, and we referred him to a renal dietitian for gout and end-stage renal disease combined nutritional needs. And he is to return in 4 weeks or sooner if he has another flare-up. But we will get these labs probably within a week or two, and we will call him in if there is abnormal levels. Maintain transplant eligibility appointments and continue as instructed. This has been Jose Enriquez with U.S. University, and this is my case study.